Hello, everyone. I'm Carol Fleck, and on behalf of the ADDitude team, I'm pleased to welcome you to today's ADHD Experts presentation titled Combination Therapy, Medication Strategies for Hard-to-Treat Complex ADHD. Leading today's presentation is Dr. Timothy Wilens. Dr. Wilens is Chief of Child and Adolescent Psychiatry and co-director of the Center for Addiction Medicine at Massachusetts General Hospital. He's also a professor of psychiatry at Harvard Medical School. Dr. Wilens specializes in the diagnosis and treatment of ADHD, substance use disorders, and bipolar disorder. In today's webinar, we'll discuss complex ADHD. That's when a person with ADHD has one or more coexisting conditions. And we'll learn about the medications used to treat these diagnoses. As many of you know, ADHD rarely travels alone. Depression, anxiety, mood disorders, and autism are often comorbid with ADHD. In today's webinar, Dr. Wilens will explain the common conditions and symptoms that can accompany ADHD, and he'll tell us about medication strategies to guide patients and their providers. We'd like to begin today's webinar by asking this poll question to our live audience. How has the ongoing ADHD medication shortage impacted your ability to manage ADHD and coexisting conditions? Please select your answers and comment in the text box under the video player to tell us more. For answers to common webinar questions about slides, transcripts, and certificates of attendance, click on the FAQ tab of your webinar screen. If you support the work we're doing here at ADDitude to strengthen the ADHD community, we encourage you to visit additudemag.com/subscribe and sign up for ADDitude magazine. The summer issue is out now with lots of great advice on medication management for newly independent young adults, and scientists tell us how the ADHD brain is wired for loneliness in some people. So subscribe to ADDitude magazine today for yourself or to share with a teacher or a loved one who could benefit from greater ADHD understanding. Click the magazine tab on screen to learn more. Finally, the sponsor of this webinar is Play Attention. Empower yourself by developing strong executive function and self-regulation. Cognitive control is your superpower. Play Attention can help you develop it. Backed by research from Tufts University School of Medicine, Play Attention empowers individuals to improve attention, emotional regulation, and overall performance. Its NASA-inspired technology ensures tailored support for every aspect of life. Click the link on screen to take Play Attention's ADHD test, or schedule a consultation to start your journey toward improved executive function and emotional regulation. Call 828-676-2240 or visit playattention.com to learn more. ADDitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. So without further ado, I'm so pleased to welcome Dr. Timothy Wilens. Thank you so much for joining us today and for leading this discussion.
Well, thank you very much, and I really appreciate ADDitude taking on issues that are a little bit more, a little bit more difficult and challenging. And these are the group of individuals that I've worked with my entire life and have dedicated my professional career to, both studying in terms of new treatments, but also clinical care. And I want to welcome everybody from a very beautiful Boston, Massachusetts. So we're going to be talking about complex ADHD, and I'm going to add a little bit to this in terms of talking a little bit about refractory ADHD also. I'd like to start with my disclosures, and I do work with a company that's in this area and have confidentiality disclosures with others. Most of my disclosure is about my clinical work, where I do work with psychopharmacology, and I also work with addictions. And there may be some questions about that at the end when it comes to comorbidities. So in terms of sort of an overview to ADHD, I know most of you know this, most of you can give this part of the lecture, but I just want to remind everybody that it's considered, within 6 to 9%. A very recent publication came out just slightly higher but roughly 6 to 9% of the population, and about 4 to 5% of adults. So the former figure was more for kids and adolescents, and the 4 to 5% is adults. About 50% of individuals who are children today will continue to have adult ADHD into adulthood. If you're starting with an adolescent, a 16 or so year old, how many of them will continue to have it into adulthood? At least 3/4. And then there's arguments about, how I define it and this and that. But generally, that's what you can expect. We're going to be addressing this. It's associated with high degrees of psychiatric comorbidity, co-occurring problems like you have ADHD and depression, or ADHD and bipolar, or ADHD and anxiety. It's associated with impairment. So the reason we're talking is because this is not just a cosmetic disorder. I don't need to be telling you about that if you're living with a loved one with ADHD. It causes a lot of impairment, it causes struggling, and it causes suffering. And those are the three major benchmarks to when do I think, as a psychiatrist, I need to treat somebody pharmacologically or with some type of a psychotherapy. So I'm going to jump right into starting with the various medications that we have, and to remind everybody that we have actually a growing portfolio of medications that are available, such as we have the stimulant medications that are FDA approved. We have Atomoxetine, and I'm going to go back and forth between brand and generic names because sometimes people don't know that that's Strattera. We have alpha agonists, which are FDA approved. Things such as guanfacine extended release, also called intuitive clonidine extended release, which is referred to as Capve, although there's a new one. Oneida is a new, we're just commenting about it. That's a new FDA-approved long-acting clonidine. And then you can use clonidine extended release or guanfacine extended release with stimulant medicine. So the combination is actually also approved, and we're using that combination. And that is going to be one of the things we're using for refractory cases or cases of comorbidity. So what else do we have? We have Viloxazine XR, which is also just recently available. More recently, it's Qelbree, and that's a non-stimulant that works. And I'm going to be walking through the various treatments we have. So let's start with the stimulant medications, and let's start discussing things such as methylphenidate. Now, this is a relatively complete. There's always, name shifts or whatever, but this gives you sort of what is available with methylphenidate preparations to help treat individuals with ADHD. I'm starting with the assumption that sometimes people aren't better with their ADHD because they still have core symptoms. They have comorbidity we'll talk about, but they still have some core issues with the disorder. And when you're thinking about that you're still having active symptoms, one of the considerations with stimulant class medicines is to go up on the dose. There is a very robust literature that shows as you go up on the dose, typically you get better response for your ADHD. Low doses work. Moderate doses typically work better than low doses, and higher doses work better than low or moderate doses. Now, in some individuals, as you go up on the dose, they actually get worse. So you can't just ramp up doses rapidly. You always want to bring up the dose slowly, but it helps to understand that. So, we have a number of methylphenidate, different preparations, 15 different preparations that I recently looked at the literature, and that seems to be what we have. The doses that we often go to, especially with methylphenidate class agents, is higher than the FDA-approved dose, only because not as much methylphenidate as you give gets into the system as you may imagine. Only about 20% of what you actually ingest actually gets into the system. And because of that, because of wide differences in how much gets into the system, it may be that some people require higher doses and conversely some lower. The other thing we think of is we recognize that there's different types of methylphenidate agents. In other words, there's long-acting, short-acting, intermediate-acting. The short-acting ones may be more appropriate in children. So, for example, Ritalin IR, Focalin, those are considered shorter acting, and they last 4 or so hours. For preschoolers, those may be helpful for adding on to an extended release preparation that will cover ADHD later, and that's often a problem. And then another clinical pearl is in individuals who have a lot of mood dysregulation, moodiness with stimulants, especially an extended release. Let's say you're using an extended release stimulant. Consider using a short acting. We sometimes find that that works so much better. The other thing, reason I kind of highlight the various preparations of methylphenidate is so you have duration differences, but also how you administer. You can give them, like most people do, like a tablet. You can have capsules that you open and spill, and that can help certain kids who have problems, taking oral pills. You have liquid suspensions that can help kids who have problems taking pills. It also is great because you can go milligram to milligram, and you can get just the exact dose using that. We have patch technology where you actually wear a patch for people who don't want to take oral things or people who may have GI issues. We have ones that you take in the morning, and then we have ones that you take at night, a stimulant that releases the next day and helps and works really well if you have kids who have a lot of morning disruption, let's say. So it's great to have a whole variety. And that's just for methylphenidate. To remind you, we also have amphetamine class agents. We have 10 of these, still a lot. And these are very similar in terms of different long action, short action, intermediate action. Adderall, dexedrine tablets tend to be on the shorter side. And then you've got things such as dexedrine spanchules that are more intermediate. And then we have extended release like Adderall XR, Vyvanse, which by the way is generic now. And then you've got these long ones like Mydayis, which is a very long preparation lasting to 16 hours. And again, they have suspensions, they have patches of this so that you can really give it in any different version of preparation, which is often part of the problem for, quote, refractory or non-responsive ADHD. There's many things you can do that to get around so that you can still use stimulants. Now, this is a little bit complicated. I'll just walk you through. This is really a chart that looks at switching from initial stimulant, and this is more focused on adults. But what it basically says is that people who don't respond to methylphenidate class agents should be tried on amphetamine because you're going to, in many cases, get people do better and they like to switch. And the same, individuals who start with amphetamine preparations and for whatever reason have side effects or don't have a good response should be tried on methylphenidate preparation. So we frequently shift class from this one, from methylphenidate to amphetamine or amphetamine to methylphenidate. In general, if you look at guidelines plus clinical practice, typically kids are started on methylphenidate class agents. And then if they've tried different ones and not to satisfaction, there's refractory cases, they'll move to the opposite, to an extended release form and then on to a amphetamine class agent. In contrast, adults are often started on amphetamine class agents first, and then we'll move to methylphenidate if there's usually untoward side effects or the tolerability is not very good. Before we exit, again, a big reason that people stop medicines is because of side effects. And as part of complex ADHD, it's comorbidity, but it's also being able to use stimulants because they're so effective. And, you need to monitor if they have cardiac issues such as chest pain, chest discomfort, shortness of breath, you're going to have to stop it. And you're going to want to go to a primary care doctor or cardiologist to be sure that there's not underlying issues. If there's insomnia, problems sleeping, is this always been there and it's just gotten worse? Or is this like new and really worse? Sleep hygiene is really important. Getting to bed at the same time, waking up at the same time. You can't tell people when to go to sleep, but you can wake them up. Not playing video games too late, not doing exercise too late, not drinking caffeine too late, watch afternoon or late doses of medicines. What other medicines? We use melatonin. Melatonin has been shown to be effective, both short and long term. We use clonidine. One of the treatments of ADHD can really help with sleep. Sometimes we use tricyclic antidepressants. Those also are effective for ADHD, but sometimes at low doses, those are great sleepers, and they help treat the ADHD at night and through the morning. And then mirtazapine, which is an antidepressant in adults, but has been used for sleep for many years, using it at a low dose. Low dose seems to be best. Dental issues, people who are grinding, wear guards. One thing to realize as you get older, teenagers, young adults, dry mouth is one of the most common side effects. So be careful and use, good dental hygiene, keeping your mouth wet, not eating sugared candies, because sugared candies on top of a dry mouth, that will create dental caries very quickly. And finally, with mood and irritability, which is a comorbid condition, evaluate when it's happening. If it's at the peak, like 2 to 3 hours after, you're going to have to try a different preparation totally, because that's indicating that. Is it occurring during wear off? Well, you can try microdosing stimulants later. You can try omega-3 fatty acids, good old omega-3s, they work. The other thing is, if it's a comorbidity that you're seeing unveil itself, then you're going to think about treating mood. So you may have somebody in therapy, or you may think about shifting to a different preparation of a medicine, or treating the mood with a medicine and treating the ADHD. So let's move on to other things we're using. And Viloxazine is interesting. It's a non-stimulant. It's a noradrenergic agent. It's approved across the lifespan. The dosing is 200 in kids, 400 in adolescents, and up to 600 in adults. And I go up by 100 milligrams a day. I'm not in any big hurry on that. The side effects, it's generally well tolerated, but it can cause somnolence in some cases, and sometimes just the opposite. Sometimes a decreased appetite, like a stimulant, and sometimes headaches. That's been shown across the lifespan. You know, in terms of dosing, like I said, I usually start it, for a lot of people who haven't used this yet, start it relatively slow at 100 milligrams and go up 100 milligrams a week. You know, I don't bump into as many side effects, and sometimes I get a really good response at a lower dose because I'm not going too quickly. A couple of things to know. We are thinking about using this for individuals who have mood in addition to ADHD. It's an antidepressant in Europe for years, and we're thinking more and more that this may be a really interesting agent for mood and ADHD. In fact, my understanding is the company's doing a study right now to look at that. So, and I have experienced that, like mood dysregulation with ADHD, this irritability, real frustration that is really hard on both parents and the kid or the individual if you're older, that sometimes gets better with just using Viloxazine. A couple things to know. It is a strong inhibitor of one of what we call an isoenzyme in the liver. And because of that, the 1A2, you have to be a little bit careful if you're using certain things like other psychiatric medicines like duloxetine. There's other ones to be concerned about. So just anybody on it should take a look at that. The other thing company indicated to me is be careful about caffeine, because it may accentuate caffeine. In other words, you have your Starbucks in the morning and it's like having two. So be careful about caffeine also. I want to note that there's some medicines that care a lot about if you start them earlier or later. And one of those medicines is Atomoxetine, Strattera. In other words, it doesn't work as well as if you've started a stimulant and then Atomoxetine, as opposed to most non-stimulants don't care if you've been on another medication first. And why is that important? Because if we're talking about Atomoxetine, we're really talking about use of the medication often for ADHD plus anxiety. So comorbidity with anxiety, think Atomoxetine. It's a very good medicine for ADHD and anxiety. There have been studies that in children, adolescents, and adults that show improvement in the ADHD and the anxiety. In fact, it works as well as many of our medicines we use for anxiety, such as what we class as a medicines called the serotonin reuptake inhibitors, the SSRIs. Works just as well. It's also helpful for tic disorders and maybe for disruptive disorders. Another one that we often use Atomoxetine for is ADHD plus substance use disorders. We're not going to spend a lot of time talking about substance use today, but if you have that and you say, I want to use a non-stimulant, many of substance users also have anxiety as a problem also in addition to their ADHD, and it will help the anxiety, the ADHD, and it will reduce episodes of, let's say, heavy drinking or heavy smoking for those individuals. So Atomoxetine is a good one to know about. Doesn't have a lot of drug-drug interactions. That's been studied in substance users, for example. Another thing to think about that often people ask me about is what do we do in older, like adolescents and young adults? And one of the things you can do is add guanfacine extended release. People are using that already. It's a very common medicine. But what you may not know is you can go to higher dose. So there was a study that we published a few years ago, a multi-site large study, and we dosed it up to 7 milligrams a day in adolescents. The highest dose typically was roughly around 6. Most people didn't need the 7 or didn't want to go to 7. And basically, it worked quite well in terms of treating ADHD. It was effective, no surprise. And I've used that in my practice a lot, up to 6 milligrams a day. I have a number of adolescents and adults who were responding, but their response wasn't as good. So we just increased the dose. So again, data to support that. So let's talk a little bit about some of the psychiatric comorbidity that people have. And I'm going to start with a little bit of a case. A 7-year-old with ADHD plus excessive difficulties with organization, time management, thinking sequentially, shifting what they're working on and stopping. And when we think about that, we think about it in terms of ADHD and executive functioning. And what a lot of people say, what is that? Cognitive executive functioning, I call it the Wilensism, is the secretary of the brain, kind of helping you. You do this, you organize. Organization is the symptom that really taps into it. But time management, initiation, shifting, stopping. That's all under that rubric. And some kids and adults, about a quarter of those with ADHD don't do as well with that. These kids have more problems with disruptive behavior, more anxiety, depression, social functioning problems. It really causes a lot of issues. So what can you do about that? Well, we just published a paper, and there's multiple positive treatments for executive functioning in ADHD. So you can do physiologic, you can get out and you can do jumping jacks every day. So exercise helps, but on the day you do it. And it doesn't have to be a lot, but that has a big impact on it. There are treatments like cognitive behavioral therapy and organizational training that have been shown to be effective. There are neurologic things like neurofeedback and stuff, not so helpful. I wouldn't do that. We did not recommend that in our paper. And then there's digital. There's some online gamification things, CogMed. There's other ones that are available that had some impact, some effect. Problems we have with some of the available digital ones is some of them are very expensive, and some of the ones that we reported on are not available. And finally, there's pharmacologic, and I'm going to talk about that in a second. So one of the things we found is, first of all, stimulants can help, but they often are not sufficient to manage all the executive functioning. We're starting to see that some of the non-stimulants, like Strattera, Atomoxetine, Calbri, or Viloxazine, seem to help. And then when you mix non-stimulants, like I just commented, with stimulants, you can get impact. In fact, if you look at Atomoxetine, Strattera, and stimulants, there have been a number of studies, and we did a big study of this. And basically, an analysis of all of the studies done, 10 studies, showed that the available evidence suggests, but does not confirm, that this drug combination, that is atomoxetine plus a stimulant, methylphenidate or amphetamine, may benefit some, but not all patients who have tried several ADHD medicines without success. So it is something to think about. Just add a non-stimulant with a stimulant, and that may be helpful. Well, what else has been tested? Well, as I was indicating, you can use an extended release form of a alpha agonist like guanfacine extended release or clonidine extended release, plus a stimulant. Those are FDA approved. They improve ADHD. And there was a small study from UCLA that showed that it actually also improves executive functioning, secretary of the brain, organization, time management, etc. So one of the ways to manage what I think of as a cognitive comorbidity of executive function and in ADHD, then you can think about using 2 medicine combinations if necessary. Another thing we're using is a medicine that's used for Alzheimer's called memantine. And there have been studies that have looked and focused on executive functioning, looking at it, there's different ways to measure it, but finding, if you look at it clinically using clinical scales, that you see some improvement, and I found it with memantine. So memantine is another one, dosing 5 to 10 milligrams twice a day. They have an extended release also that works. And it may also be helpful for social cognition, the capacity to read verbal cues for kids who have ADHD plus some autism or autism spectrum. The other thing that works in this realm, even though I'm focusing on pharmacotherapy, or like I was commenting, is for residual symptoms of ADHD and executive functioning, thinking about psychological treatments like cognitive behavioral therapy and organizational training. Those are sort of the 2 big areas. Not my group, but another group at Mass General has a guide on this, for example. And they've published data showing significant improvements in kids who were treated with cognitive behavioral therapy. These are largely medicated kids, so it's not verse medicine. It's medicated kids who are still struggling, which is a very common scenario with executive functioning. And what they found is that it works. So this is what they focused on is organization and planning, how to deal with distractibility, how to reset things if you start to get, off of things, and how to deal with procrastination. So you think about it, organization, planning, procrastination, those are all what we call executive function. And the response rates for individuals by self-report or parent report were between 50 to 60%. So pretty good outcomes for kids who had stable medicine regimens, but still had a lot of cognitive executive functioning. But let's move on. What about the tough thing about autism spectrum disorder? And we know that if you look at samples of ADHD, if you look at rates of ADHD in community samples of kids with autism, it's anywhere between 20 to 30%, and it goes up to 50% if you look at clinical samples. So lots of autism in individuals with ADHD. I apologize if you're hearing sirens. It's usually not that. I am in a general hospital, so there are sirens, and not much we can do about that. But so sorry, it seems like they keep coming by. We recently reviewed the literature on autism and ADHD treatment. How do you treat autism plus ADHD? And you probably know that in the older versions of our diagnostic statistic manual, you couldn't have both disorders. You could just have prominent hyperactivity. But now you can have autism and ADHD. Because of that, there's increased diagnoses. And a couple of things we've learned is, first of all, there was a large study done a number of years ago called the RUPP, Research Units in Pediatric Psychopharmacology, and they studied treatment of ADHD. They didn't look at ADHD per se. They looked at hyperactivity because at the time that's what they could do. And what they found was improvements in ADHD symptoms, the hyperactivity, but the response rate was closer to 50%, not the regular 70 to 80% we see in neurotypically developing kids. So signal number one was it didn't work as well in these kids with more significant autism. And number two, they had more side effects. So it didn't work as well, and they had more side effects. The good news is it seemed to help something called self-affect regulation, losing it. Kids tended to lose it less when they were treated. So studies like that and a whole host of other studies that we reviewed showed that ADHD can be diagnosed in autism spectrum and should. Pharmacotherapy is effective, but one thing we've learned is if you have what we consider intellectually capable patients with autism spectrum and ADHD, the response rate to using non-stimulants and stimulants is pretty much the same. If you have lower functioning autism spectrum, be careful with both stimulants and non-stimulants. And both of what I'm talking about refers to both stimulant and non-stimulant class medicines, mainly methylphenidate, mainly atomoxetine, a little bit less with clonidine. Didn't work quite as well. But the other non-stimulants and the stimulants seem to. If you're working with lower functioning autism spectrum or a lot more autism traits in ADHD, careful, your effectiveness is not going to be quite as good as it is with kids who don't have autism spectrum and ADHD. You'll have more side effects, dysregulation, appetite issues, sleep issues, pretty much everything goes from here up. It just becomes more significant. And consider different preparations. You may have to get more fancy about what you're using. For example, sometimes tablets work great and you can grind the tablet. Sometimes the kids won't deal with tablets. Some you have capsules that you can open and sprinkle on food, and that works okay. They have dissolved tabs that you can dissolve in your mouth. They have suspensions pretty much for stimulants and non-stimulants now. And they have patch technologies. So think about what is the best way to work, because these kids often bring a whole set of other issues with them. Now I want to shift a little bit. Let's look at this case, which is an 8-year-old presenting with ADHD and excessive worry, somatization, thinking a lot about physical things, stomach aches, headaches, and things like that. Always feeling on edge, worries about what others are thinking, and has sort of isolated anger that's kind of related to the above. So what do we think about that individual? Well, we would say that they probably have anxiety disorders along with ADHD. Anxiety is one of the most common co-occurring issues with ADHD. It is absolutely very common. And in fact, it can sometimes be hard to know, does somebody have ADHD or anxiety or both when they both co-present, because they both start early in life. They both have a lot of overlap symptoms, and both cause quite a bit of impairment. If you've decided and figured that out, what it is, what do you do? So, certainly the stimulants people use, but then they get worried about, well, are they going to cause problems, with people with anxiety? And there's been some recent meta-analysis that actually shows anxiety may get a little bit better. And it depends what you're looking at. Is it just panic attacks or worries? Yeah, I'm not sure they get a lot better. I think sometimes they can get worse. But then are you talking about avoidance of things because you have ADHD and cognitive problems? Well, those do get better. The net result of the meta-analysis, of sort of a study that looked at all the studies, is that treatment with psychostimulants actually significantly reduce the risk of anxiety compared to placebo. But it doesn't rule out the possibility that some kids get worse. And I have to tell you, if you're a parent out there of a kid, or you're somebody with ADHD and you've had that experience, as a clinician, I see that all the time. So I think we're always looking to see, are we making things worse? But it used to be like you can't use stimulants in those situations where there's anxiety. And now we've rethought that. That's been a shift in the field to say, no, go ahead and try them. Keep an eye on the anxiety, but it's not automatically you can't use that class. My favorite go-to, however, for anxiety and ADHD is Atomoxetine. I described it earlier. And what's remarkable is that there's real improvements in the treatments for the outcome for both ADHD and for anxiety. ADHD gets better, anxiety gets better. But again, a caveat about Atomoxetine or Strattera is that if you're going to use it, I recommend, if you're thinking about starting it, or if it's your child who's going to go on medicines, and you're like, do we start a stimulant or do we use Strattera? I would say start with Strattera, because Strattera response, for whatever reason, and it's been replicated, it doesn't work as well if you've been on a stimulant first. Don't understand that. But that's that. The other non-stimulants doesn't matter if you've been on a stimulant first, but Strattera does. It's just not going to work as well. So if you're thinking of a new start patient, or if it's your loved one and you're thinking, what do we start with? If there's a lot of anxiety, give Strattera a chance. And then can you add a stimulant to Strattera? Like I showed you earlier, absolutely. We use it for anxiety and ADHD. We use it for executive function. We use it for a lot of reasons. Now, I'm going to jump into a very tough one, which is bipolar and ADHD. And happy to answer questions about depression. We really don't have a lot of data with depression. It's really indirect data. And for depression and ADHD, we're either using a stimulant and a serotonin reuptake inhibitor for kids, because those are the only things that are approved. Or for adults, we're using any antidepressant with that. Sometimes we use bupropion, which is off-label for ADHD, but is an antidepressant that does help ADHD, and that does help mood, and we sometimes add to that. And sometimes we use tricyclic antidepressants, and they also help very well with ADHD and can help mood, and those are typically reserved more for adults. But when we're talking bipolar, we actually know quite a bit. And just to remind you, bipolar and ADHD have an overlap. Many kids with bipolar onset in childhood have ADHD. If you're talking about adults with the onset of bipolar later in life, lower rates of ADHD. But there is a lot of overlap with bipolar, severe mood dysregulation, outbursts, manic activity, staying up at night, not sleeping the next day, the kids being very out of control when they have what we call mixed symptoms, both depression and sort of mania at the same time, severe temper tantrums that last all day, rage attacks, destroying things. This is a group that's tough to treat. So what do we know about that? What does it look like? So let's start with just sort of a case that gives you a sense of what that feels like. A 14-year-old with longstanding ADHD who develops episodes of severe mood dysregulation, agitation, and expanded mood, thinking they can take things on, they can do anything, not just normal, healthy narcissism, but really expanded, really thinking they can do things, jump, fly, etc., along with some clear depressive episodes and poor judgment, making bad decisions, sexual decisions, spending, things like that. And a couple of things we've learned is probably the most important thing is get the bipolar disorder under control. Treat the bipolar disorder. Use mood stabilizers. You can use lithium. use antipsychotic class agents. You can use medicines like risperidone, aripiprazole, etc. There are a number of ways to treat bipolar disorder, but get that stabilized first. And once the bipolar is stabilized, you can then go back and add back treatments for ADHD. So stabilize the mood and then move and work with treatments for ADHD. I'm just going to say parenthetically that anytime you're dealing with a severe comorbid condition, and I'm talking about bipolar now, but depression would be the same, anxiety like panic attacks, things like that, substance use disorders, you really have to think about treating those disorders. And if it comes to a mood disorder like bipolar or depression or anxiety, and it's really severe and the ADHD isn't as severe, treat the more severe condition first. And almost always bipolar is more severe than ADHD. And if you do that, you're more likely to have a good response to ADHD treatment as opposed to if you don't treat that. So looking at this, we're looking at the effect of trying to get a sense of what are some of the data and what does it feel like. Well, there's been data with methylphenidate, for example, in kids where if you take stabilized individuals with bipolar disorder where their bipolar has been treated and you try ramping up the dose, 5 milligrams twice a day, 10 milligrams twice a day, or 15 milligrams twice a day of methylphenidate using just a short-acting preparation, what you see is no worsening of the bipolar disorder. Hey, that's great. And number two, you see a dose-dependent improvement in the ADHD. And this is similar to a study that was done with amphetamine. So we've had a couple of different studies, amphetamines, which was Adderall, and methylphenidate. This was just regular Ritalin. And what you see is improvements in the ADHD without activation of the mania. But that's nice, at a small sample. But what happens if you have a big sample, And this has actually been studied in adults with bipolar and ADHD in the Swedish registry study. And we all envy the Swedish registry studies because they can look at so many different components of care, including medicines that have been administered or psychotherapies that have been administered and what people are getting and taking. They ask a simple question. They ask a question, if you started stimulants before the bipolar was stabilized, what happens to the bipolarity over time? And if you started stimulants after the bipolar was stabilized, what happened? Well, what happens is if you start the medication, the stimulants before you have good stability of the bipolar, I don't think anybody'd be surprised. The adults had manic symptoms. They got very bipolar. They got really revved up, etc. And that was found all the way to 6 months out. In contrast, if you gave the medication to stabilize the bipolar first, they were stable, and then you gave the stimulant, what you found was improvements in the ultimate outcome. You actually saw less bipolar symptoms if the bipolarity was treated and then you added a stimulant. So this is, again, part of it, the whole general. Anytime you have a severe co-occurring problem with ADHD, you want to stabilize that and then treat the ADHD. In cases where there's more mild symptoms, let's say anxiety, where you're not really sure how bad the anxiety is, it's there, and it could be part of the ADHD, it's certainly worth trying to treat through it or trying a drug medicine like Atomoxetine. So I want to summarize sort of the whole treatment refractory and say ADHD is common. It's associated with short, long-term difficulties. And I think it's important that we realize that in cases where there's comorbid conditions or refractory ADHD, we have to treat the ADHD. It's not an option to say we're not going to treat it. You got to treat it because there's long-term outcomes are negative and treatment improves that. There are multiple treatment strategies available for ADHD across the lifespan, the stimulants, the non-stimulants, and often it's a dose issue or using the combination of a stimulant, non-stimulant for refractory cases of ADHD, and for comorbidity, often using that or other combinations. And then treatments exist for individuals with ADHD who also manifest cognitive, and we're working on that, sort of executive function problems. We're working on that as we speak. In psychiatric comorbidities, and again, treat the more severe disorder. Often it's a combination approach that you're going to take: psychotherapy, medication, psychotherapy, multiple medication to get control of the comorbidity and the ADHD. And I say stay tuned, new devices, psychotherapies, as we were chatting before we came on, for example, a new preparation of an extended release form of clonidine that you can give at night once a day. It's great. Give it at night. It works the next day. That's now available. But we also have other medicines that are coming to market, like cetinafidine, which it offers hope because it may help some of the cognitive comorbidities. It also may help some of the anxiety and depressive co-occurring problems with ADHD, given its sort of pharmacologic properties. So it's exciting to be in the field. There's other medicines that are in development, other psychotherapies, digital, therapies that may also work alongside some of our existing treatments to really help our kids, our adolescents, or adults get better with ADHD. So with that, I'm going to turn this back over to see if we have some questions and hopefully some answers. Thank you.
Thank you so much. Yes, we have lots of questions. But before we start the Q&A, I'd like to thank Play Attention once more for sponsoring this webinar. And I'd like to share the final results from today's poll question. How has the ongoing ADHD medications shortage impacted your ability to manage ADHD and coexisting conditions? Here's what you said. 19% said the shortage has had no negative impact on their lives, which is pretty surprising. 16% said it's difficult to find alternative ADHD meds that don't interfere with treatment for coexisting conditions. 16% said delayed access to medications has been a real problem, and 15% said there's an increased reliance on non-medication strategies. Now to your questions. Of course, we've had quite a few questions around ADHD and autism, which you addressed very well. Here, some questions are, can ADHD medications exacerbate autism traits?
Yeah, it's a great question. The answer is yes. And anytime we're trying to treat, we're going to be monitoring that. Did the medicines increase, for example, stereotypies, hand flicking, rocking, moving in a certain direction? It sometimes is difficult to know, are we talking about a complex tic, or a stereotypy? And we know that stimulants are not necessarily negative in context to tics, but they can certainly make them worse in certain individuals. So yeah, is a person more restrictive? If the person had dysregulation, kind of losing it, frustration, did that get worse? So anytime we're using these medicines in individuals with autism, we're going to watch carefully. We're not going to go up on the medicine as quickly. We're not going to go ramping up the dose really fast. We're going to do it slowly. We're going to try to get the right dose. In general, when you're using especially stimulants, you're trying to get to pretty much higher doses, because higher doses are going to give you the best outcome. You're looking for the best outcome. For kids with autism and ADHD, you're going to have to be a little bit more careful, because you may not get to the best treatment for the ADHD, but a good treatment, because if you go too high, you start having more side effects and it doesn't work as well.
Okay. Someone writes, our 19-year-old son has ADHD, autism, very high anxiety, and a mood disorder. When he has meltdowns, he gets aggressive and lashes out at my husband and me, or he destroys part of the house. He's been on medication since he was 6. How do we know if the ADHD meds increase his anxiety? And is there a place where we can take him to stop all his medications safely to see which he really needs?
Yeah, so that's a very complex case. And often, as you were indicating, you're going to be using complex pharmacotherapy. There's just almost no way around it. In terms of your latter point, sometimes you can arrange for a residential program or a program like that where your son would be safe coming off the meds. You have to be very careful when you take kids off meds. You want to be sure certain meds you're tapering because of medical safety considerations. You want to stop them too quickly. But the other option is, these are often cases when there's mood, severe irritability, and autism. The medicines like the second generation antipsychotics like risperidone, aripiprazole, and others, those two are approved, but there's other ones that don't have weight gain or other risks that can work very well. And those can help stabilize those outbursts, aggression. They can help a little bit with the ADHD, but they can also create a pocket then where you're safe to try stimulants or non-stimulants for the actual ADHD. And lastly, about the anxiety, sometimes the anxiety can respond to generic or benign medicines like buspirone. We use a lot of that in autism and ADHD where there's a lot of anxiety. You might want to try Atomoxetine. That can help and help with the ADHD and others. And sometimes just using the antipsychotic class agents also helps with some of that anxiety. But that's a very tough case. It's going to require complex interaction.
Okay. We had some questions around women's hormonal cycles. One question is, do you take women's hormonal cycles into account when adjusting meds for your patients?
We talk about it in context to two major things. Perimenstrual, like the dysphoric issues when women, and they're very tuned into this, feel like there's tremendous amounts of mood instability around the time of their cycles. And this is really independent of ADHD. There's ADHD and mood, and then they'll say it gets really bad around my cycle. And then we'll try to determine what makes sense. And then often in those individuals, we're using either medicine all the time or just during those times, or if they're on medicine all the time, they go up 10 days before they cycle and then maybe down at the time of their cycle. And we have people doing that. The other is for kids who are starting, younger kids, when, women or girls to women, menarche, when are you starting your cycles? And we ask about that because that can have an influence. And then for women who are, perimenopausal, there often are more symptoms of ADHD and other disorders. And so we'll try to get that information also. So it's, there's not one size fits all, but you're trying to take that into consideration. And then, of course, people get put on, birth control different systems, but let's say any kind of an oral or a patch or any kind of technology like that, which can then further either exacerbate or improve mood symptoms. So kind of knowing all of that and getting that into totality does affect what you're going to be doing pharmacologically.
Someone asks, is there a best way to optimize ADHD therapy in menopause? Because my ADHD is worse now.
Yeah, you have to oftentimes go, it's sort of contrasting. People are getting a little bit later in their lives. Their life burdens may be simplifying. So, in many cases, you could start reducing the meds for ADHD. And then you have a repeated finding and discussion by women that my symptoms are much worse now, my distraction, my inattention. And then in those situations, we're often increasing the doses of medicine. So there's this countervailing force that I think you need to take into consideration. At the end of the day, when you're sitting with your practitioner, if your ADHD is not well managed, certainly talk to them about, increasing, what are your options? Increasing dose, shifting preparation, trying something else. But it is a common conversation that we have. So you're not alone. And I think staying in close contact, whoever's treating your ADHD, will make it much better. You can't sit and suffer with a lot of symptoms.
Someone says, how do I convince my doctor to prescribe combination therapy for my ADHD? They're very reluctant.
First of all, I would say talk to them about, first of all, certain combination therapies are FDA approved. So stimulants plus clonidine or guanfacine are FDA approved. So they wouldn't be FDA approved unless they were both effective and safe. And I know the studies, I actually did one of the big studies, so well aware of that. Number two, other combination therapies have been used and published. So for example, if you're using Strattera and a stimulant, there have been over 10 studies on that. So there's a lot. If you're using other combinations, I think the most important thing is to realize that most of the medicines we use for ADHD are safe in combination with other meds. Some you may have to reduce or be mindful of, such as Strattera or Viloxazine with certain medicines. If you're using stimulants, there's really no drug-drug interactions to worry about. They actually don't, like at a drug-drug level, increase the levels of another drug, or another drug doesn't increase the levels of stimulants. There's no, we call it pharmacokinetic, it's a technical way of saying that. There are no pharmacokinetic drug interactions with stimulants. They're remarkable that way, quite honestly. So they're safe pretty much in combination with other medicines. So if you're on an antidepressant, or if you're on even a big gun like a second generation antipsychotic, or a medicine like buspirone for your anxiety, it's okay to do that.
Okay. Someone asked, can combination therapy help treat high-risk behavior in teens and young adults?
Yeah, so it's a great question in a preventive way. I sort of think of high-risk behaviors as sort of impulsivity driven usually. And the medicines alone, like stimulants for ADHD, anytime you're treating ADHD, you're reducing impulsivity and you're helping high-risk behaviors. For kids who have increased amounts, let's say they don't have ADHD, like conduct disorder, which is, kids who don't have the same values, societal values, harm other kids, harm animals, aren't as concerned about it. They're aggressive usually when they're very young. They get into fights, etc. Those kids actually even do better with treatments that we use for ADHD. And kids who have the combination of, let's say, delinquency and high-risk behaviors with ADHD tend to do better when you treat the ADHD. So just treating ADHD helps high-risk behaviors. And in fact, long-term data, that's another talk at some point. We've done studies on long-term outcomes. Virtually all of these long-term outcomes that we know occur with ADHD, pregnancy, motor vehicle accidents, traumatic brain injury, injuries in general, substance use disorders, all of those things that are double or tripled with untreated ADHD. If you treat ADHD over the long haul, you see those go back to almost population rates. It doesn't immunize you. It's not like you're still at risk, but like anybody in the general population. So I'm glad you mentioned that. Treatment of ADHD really does help many high-risk behaviors over time.
Wow, that's great information. We had a few questions around food addiction and eating disorders. What's the best treatment for ADHD and eating disorders?
Yeah, it's a great point because we didn't talk about eating disorders, but there's an over representation of eating disorders and ADHD. And if you start with eating disorders, you see higher rates of ADHD. And then pretty much if you work with eating disorder patients, pretty much anybody with really severe eating disorders has tremendous cognitive impairment, something that's very notable. So having said that, we strongly recommend, like any co-occurring problem, that it's addressed, that they're in treatment for eating disorders or they're dealing with it. And then you can treat the ADHD. And a lot of people say, well, they're anorectic. Can we use stimulants? Well, you can try non-stimulants first. A lot of people like to do that. Atomoxetine, Quelby, or Viloxazine. Some people use tricyclics, other things like that. But can you use stimulants? The answer is yes. And for some cases, like a lot of eating disorders are mixed. They have some restrictive eating, and then they have some binge purge activity. And the binging, where you eat and then you throw up, that whole cycle gets improved and is FDA approved to be using medicine Vyvanse. That's been FDA approved for binge eating disorder. So for people with binge eating disorder and ADHD, you can go right to a stimulant medication. So again, address the eating disorder and you can treat the ADHD, and often you have to. And I've done that in a number of cases and found a lot of successful outcomes there. I got to tell you, a lot of people I've treated, younger people, of course, and in their teens, and then I've followed them through college, and they've done really well. I'm really struck, but they do need the treatment for their ADHD. They're the first ones to say, I've got to get the ADHD treated. And we will keep an eye on their weight. We keep an eye on their if they're still purging and stuff, we'll keep an eye on potassiums and stuff. You have to monitor certain things. But I have a number of people who are no longer in treatment for eating disorders, but are doing very well now in their later 20s. So I think it's a good outcome, this combination, but you really have to address the eating disorder at some point.
Okay. We had a few questions around emotional dysregulation and frustration management, how best to treat those.
Yeah. So, part of ADHD is frustration intolerance. It's a symptom. And then, a number of people, Paul Winder, the person who did a lot of ADHD research in adults, Russ Barkley, others have talked about emotional dysregulation as a component of ADHD. It's not, other than one symptom. It is part of ADHD symptomatology in some ways because you see it all the time. And management is treat ADHD if you're treating it pharmacologically. If people have a lot of frustration intolerance, anger management / anxiety management, but they're very similar, by the way, in approaches, can be really wonderful. I think a course of sort of a resiliency training or cognitive behavioral therapy that is directed at how to manage anger, frustration, how to identify when it's first occurring, how to release yourself from that, what to do once it's starting to boil up, what do you do, how to stop being dysregulated. All of those things are components of sort of a cognitive approach to anger management. And then there's other kinds of therapy that help introduce mindfulness, resiliency, dialectic, behavioral. But I think those are helpful. For people who have a lot of it, treat the ADHD if it's still there. There's data, for example, that low doses of second-generation antipsychotics like risperidone can help. There's randomized controlled trials that those medicines at low doses can really help eliminate that.
Okay. Someone writes, my husband is a runner. He's 49 years old. He has ADHD and anxiety, and his heart rate increases on stimulants and even on Strattera. Are there other options that won't increase his heart rate?
Yeah, it's a great point. Viloxazine is something to think about. You may want to try even a tricyclic, but most of the medicines we use for ADHD increase heart rate. And the other thing they do, we did a study, a three-dimensional cardiac imaging study and graded exercise testing. And what we found was that it didn't cause damage to the heart. In fact, it looked like a conditioned heart after 6 months on medicine, very similar to football teams. But to your point, something that I actually talk about because I work with athletes is it's called heart rate recovery. And that is how long does it take your heart to slow down after you do physical activities? You know, if you run sprints or if you're out there on a fast walk or if you're really lifting weights or you're swimming or you're doing anything, you're skiing hard, your heart rate goes up and then it comes down pretty quickly. Stimulants prolong heart rate recovery. It takes longer for your heart rate to come down. So that's one of the things to think about, that's just going to happen. There's not much you can do about it. When I work with hockey players, lacrosse players, things where there's a lot of sprint swimmers, I tell them it's going to take longer and it doesn't mean you're deconditioned. And our cardiologist colleagues who reviewed those data said that it's not putting you at increased risk for any kind of negative outcomes. In terms of your husband, there are things we've done when we've had elevated heart rates that can sometimes help slow them down. We sometimes give a class of medicines called beta blockers, like propranolol or inderol. We use that for ADHD when it causes a lot of grinding, when there's a lot of tension, for people who say that their heart rates go up and they don't like that feeling. And we usually do it after they've seen their primary care doctor or cardiologist, where they say there's no pathology underlying. You know, a racing heart, especially much above 120, 140 for somebody on a stimulant, you really need to go see somebody to say that shouldn't happen. It could be signaling there's something else underlying. Well, let's say you have that workup, it's normal. Then we add beta blockers, and that really helps cut back that. Sometimes in kids, we use the alpha agonists like clonidine and guanfacine. It turns out those slow the heart rate also. Can you use those in adults? You can, but there was a study in adults using guanfacine extended release, and I think it's like 20% of the people dropped out because of their heart rates went so slow that they started feeling like dizzy. So it's not always the best intervention to use an alpha agonist, but beta blockers can work.
And we had a few questions around OCD and ADHD, how to best treat those.
Yeah, that's a
condition.
Yeah, to remind people, OCD is obsessive compulsive disorder. You either have a lot of thoughts that are bothersome, that are hard to get rid of, or rituals that you're doing that repeat, that you have to do to release anxiety, that are also cause distress. And what we found is that if you start with OCD and you look at the rates of ADHD, about 50% of kids with OCD have ADHD. A lot smaller group of kids with ADHD have OCD, but a lot of people with OCD have ADHD. And you really don't know it until you treat the OCD. The treatments for the OCD are, you know, certain types of psychotherapies can be very helpful, and then using medications. And the medicines that work the best are serotonin, specific reuptake inhibitors, SSRIs, or serotonin norepinephrine reuptake inhibitors, SNRIs, in that order. So SSRIs is a little bit better than SNRIs, but those work. And Afrinil, you can treat the OCD, and then you go back and treat the ADHD. And if you have good control of the OCD, it's similar to pretty much every other comorbidity. If there's good control of the co-occurring problem, then you can go and treat the ADHD. You can use stimulants or non-stimulant medicines. I have a number of individuals I've treated in my life who have OCD, ADHD, and again, very rewarding outcomes. You get both of them under control, and they do much better in life. I will say that it's not like you just pick a medicine and that's it. I mean, it's always coming back, and they're doing fine for 6 months, a year, 2 years, and all of a sudden something's gotten worse. Part of it is OCD cycles, anxiety cycles. It's not like it's always at a certain level. It's better, it's worse at different times, and you're going to have to manage that by upping or decreasing your medicines. And then sometimes another sort of clinical pearl is it's not uncommon that people come to me and say, I need to get my, I have comorbid whatever, depression, mood, OCD, anxiety, and my ADHD all of a sudden got worse. And sometimes what it is it's actually the co-occurring disorder is getting worse. And if that gets worse, the ADHD gets worse. And all you have to do is treat the co-occurring problem, get that under control, and the ADHD treatment works again. So it's something that we've learned, and we actually published a paper almost 20 years ago about that phenomena. So, if there's another disorder with ADHD and that disorder starts to destabilize or get a little bit worse, which happens, the ADHD treatments that was working beautifully doesn't work as well. And rather than muck around and go to high doses of your ADD treatment, remember to keep an eye on the co-occurring problem, because that may be what the offender is.
Okay, such great information. Thank you so much, Dr. Wilens, for joining us today and for sharing your expertise with our ADHD community.
Thank you so much for having me.
And thank you to today's listeners. If you would like to access the event resources, visit ADDitudeMag.com and search podcast number 508. The slides and recording are posted a few hours after each live webinar. If you're listening in replay mode, simply click on the episode description. And please know that our full library of ADDitude webinars is available as a podcast. It's called the ADHD Experts Podcast, and it's available on all streaming platforms. We hope to see you again next week for our free webinar on bullying and its effects on the brain. Make sure you don't miss future ADDitude webinars, articles, or research updates by signing up to receive our free email newsletters at ADDitudeMag.com/newsletters. Thanks, everyone. Have a great day.